HIV for simple understanding of undergraduate students. So let's start. So what is this basically? So we all know it's a retrovirus. Means it has a beautiful enzyme called reverse transcriptase, which will basically convert or synthesize DNA from the viral RNA after infecting the host cell. So we had this retroviruses. You have many types. You have a lentivirus group and the delta retrovirus group. So how did this HIV start? So we all know that it is basically in way back in 1980s. They noticed that some rare diseases or possibly benign diseases were increasing in particular communities, particular group of people, like for example, IV drug abusers as well as homosexuals. And it seemed like they had no immunity at all. They were affected by each and every smallest organism, and that is how the basic diagnosis part started. And slowly they were able to define and say that it's a new syndrome, which is they named as a acquired immunodeficiency syndrome. So when you look at the virus, it's around 80 to 110 nanometers in size. It's an enveloped virus. So obviously, like most of the enveloped viruses, the envelope is taken from the host cell membrane, whereas the protein is produced by the virus itself. So this particular virus has two important glycoproteins, which is GP120 and GP41, which is very important for attachment and the pathogenesis of infection. This is the basic structure of the virus. From GP120, GP41, reverse transcriptase, the core, the RNA, all these are the most important parts of this particular virus. So first we'll talk about the nucleocapsid, which is icosahedral symmetry, and it has basically two major components. One is the RNA, which is two copies of single-stranded positive sense RNA, and it has the enzyme reverse transcriptase. Along with that, it has some integrases and proteases as well. Now, when you look at the antigenic structure, it has 3 structural genes and 6 non-structural genes. So, basically, 3 structural genes means it is required for the virus to be multiplying and be active. Regulatory genes are those ones, or the non-structural genes are the ones which do not actively involve in the formation of virus, but they can regulate when the virus has to multiply and when it has to be in a latency period. So first we'll talk about the structural genes. You have the GAG gene, which basically codes for proteins of the core and shell of virus. This will give rise to a precursor protein, what is called as P55, which is divided into or further is translated into P18, P24 and P15. Then you have the pol gene, which is basically necessary for all the viral enzymes, reverse transcriptase, protease, and integrases. Again, this can give rise to proteins P31, P51, P66. Then you have the envelope genes, which is basically comes as a GP160, which is cleaved into two components, GP120, that will basically bind the virus to the CD4 molecules, and GP41, which is the fusion protein of the particular virus. Now, non-structural genes, again, they are important in pathogenesis, but not exactly for multiplication of the viruses. So, they can be essential regulator genes and accessory regulator genes. Now, the beauty of HIV virus is the high rates of mutation, and the errors are high because of the reverse transcriptase enzyme, and most of these mutations will happen in the envelope genes. So that keeps on mutating. So what will happen? The HIV virus can easily evade the host immune response, and preparing a vaccine against this virus also becomes more difficult. Mainly, we can group the HIV serotypes into HIV 1 and 2. HIV 1, you have the main serotype, which is the MNO types, which are the major types of antigens or serotypes. Now, these can sometimes have subtypes. Like you can have A1, A2 or F1, F2. The M group has mainly subdivided into major subgroups, which is A to K. Okay, again, they can have subtypes or subtypes also. Sometimes all these can recombine and form a different variants, which are called as circulating recombinant forms. Now, at this particular time of infection, the patient can have a particular type of HIV-1 virus along with the CRF form. So, this is called as a quasi-species infection. So, what does it mean to us? Is it really important? No, it is not. It has no difference in pathogenesis. It just tells you the geographical location, or it can just guide you to understand the geographical uh, prevalence of that particular virus. For example, subtype A is common in West Africa, subtype B is prominent in Europe, America, Japan, and Australia. Subtype C is seen everywhere else. Okay, so and the greatest diversity is seen in West Africa, where they think that right now the virus originated from Africa itself, the Cameroon part. Transmission wise, the African and the Asian subtypes are most prevalently transmitted by heterosexual transmission, whereas the American types are more by blood and homosexual contact. The HIV-2 virus also has different subtypes A to H, and they are mostly confined to Africa and few other areas like India as well. So among them, the group A is more common. Pathogenesis, we all know the virus is maximally transferred by blood and blood products, genital secretions, CSF. The sexual mode, whereas the heterosexual mode is commonest mode, but the transmission is very, very less. Whereas the anal intercourse or homosexuals, they are higher risk of transmission compared to heterosexual mode. Blood transfusion is the least common because of the prevalent practices, but once, if at all it happens, it has a very high risk of transmission. Other methods, you have the percutaneous or mucosal transmission, very less effective. There can be needle stick injury, injection drug abusers, sharing razors, tattooing, or splash on the infected blood on the eyes or mucosal membranes. The pathogenesis wise, you know that you have the one of the most important things is the perinatal or the vertical transmission. So here the risk of developing infections around 20 to 40%. The transmission is maximum during delivery, and it may occur during any part of the time, but the paturation time is the most important part or timing where the infection can happen. And this is more if the mother has been recently diagnosed with HIV or recently developed an infection. The viral load is maximum in the blood and body fluids and CSF. It can be variable in breast milk and saliva, and sometimes not there in other body fluids or urine. Saliva can contain some inhibitory substances which can prevent the transmission of virus. Now, if you see how this virus attaches, you have the main attachment with the CD4 receptor. The CD4 receptor can also be seen on other helper T cells like monocytes, macrophages, Langerhans cells, astrocytes. All those things, the main receptor is this particular thing. Now, to make this bonding stronger, you have a co-receptor, which is your CXCR4 or CCR5. What is the advantage of this? Sometimes there's a mutation of CCR5 molecules where some lucky people can avoid this attachment of the HIV virus itself. So they are completely resistant to HIV infection. Means there's no, if at all the attachment happens, also the progression to the HIVs or the AIDS, proper clinical AIDS is delayed. Sometimes there can be a dendritic specific lectin receptor, which may facilitate the HIV by dendritic cells to lymphoid organs, where HIV replicates further in the T cells. So, what happens in the replication? These are the main steps: the fusion, the penetration, uncoating, reverse transcription, reintegration, integration, and latency. And finally, it goes in for proper viral multiplication or budding. So what happens first? The virus has to go and attach to particular CD4 cells, and it has to fuse nicely. Once it is fused, the core or the capsid is completely sent inside. Once it goes inside, the reverse transcriptase enzyme is activated. It has to go into the nuclear area where it will slowly uncoat and the reverse transcription happens. They'll slowly, the components will integrate with the host cell genome, which is called as a provirus. From here, whenever necessary, the transcription can happen, which will finally end up in translation and formation of viral components, assembly of the virus, and slowly buds out as a new particular progeny virus. So, what happens with this HIV infection? Generally, within 10 years, around 80 to 90% of people will develop an infection. Some can be quite fast and then termed as rapid progressors. Some people can have a very slow progression around to 30 years also, wherein when you take the blood sample, they show less than 5,000 HIV copies, which is very, very less. And they can be a very small subset of what is called as a elite controller, where they are around 10 to 30 years, but the the number of HIV copies, the RNA copies are less than 50 copies per ml, which is a very, very small percent of less than 1%. So what happens in this acute HIV disease? And once the infection happens, what happens? So the HIV virus enters, it will go to the lymph nodes and other lymphoid organs. The multiplication occurs in the T cells. So obviously the T cells will be destroyed. Once the number of virus is more, it will slowly come into the bloodstream, which is called as a primary viremia. This will be along with this particular point of time, a patient will develop some kind of flu-like illness, and they can also be a very significant drop in CD4 cell counts at that particular point of time. After that, what happens? The body slowly recovers, the immune response within a month of time, both the CMI, that is your cell mediated immunity, as well as the humoral response has been seen. The viremia will slowly drop down, so the CD4 cell counts may become normal, but this particular immune response cannot completely clear off the infection. So HIV will be inside the cells, the lymph nodes itself, and it will go on with the viral replication. And this is your latency. It can last for around 10 years and sometimes up to 30 years also. Once the latency is broken, or some trigger mechanism which allows the virus to again start replicating, there's a rapid progression, and the death is usually, if you don't treat the patient, he'll die off in 2 years, mostly because of opportunistic infections. There's a stage called persistent generalized lymphadenopathy, where the replication of the HIV virus will cause some lymph nodes to enlarge around more than 1 centimeter in size, and it can persist for more than 3 months' time. Then you have the symptomatic period, where after latency, once the CD4 cell starts falling, the patient will develop symptoms like unexplained diarrhea for more than a month, weight loss of more than 10% of the body weight, some fatigue, tiredness, night sweats, mild opportunistic infections, and oral thrush. Later on, when the disease goes into advanced stage, there's a rapid fall. The CD4 cell counts, high viral loads are there. The lymphoid tissue is finally given up and it is replaced by fibrous tissue. Humpty number of opportunistic infections, development of neoplasias, and development of HIV manifestations like encephalopathy. In this picture, if you see, there's a very beautifully shown the as the number of CD4 cells fall, the infections which happen. So when the CD4 cell falls to around 500, you have more multiple bacterial infections like followed by Kaposi sarcoma, tuberculosis, PCP, and your Mycobacterium avium complex infections and lymphomas. So clinically, when you want to identify, you have or classify, you have two different systems: the CDC system and WHO system. So generally, what we follow is the WHO system is based on the clinical conditions of the patient. So the stage 1, you have an asymptomatic HIV infection, and patient may have persistent generalized lymphadenopathy. This slowly goes into stage 2, where the patient has unexplained weight loss of less than 10% of the current body weight, recurrent respiratory tract infections, herpes zoster, angular cheilitis, recurrent oral ulcers, some eruptions here and there, and seborrheic dermatitis. This is followed by the stage 3, where the weight loss is more than 10%, unexplained chronic diarrhea of more than a month, unexplained persistent fever of more than a month, oral candidiasis, oral hairy leukoplegia, pulmonary tuberculosis, severe bacterial infections, acute necrotizing ulcerative stomatitis, unexplained anemia, and you'll have some the cell counts which will be much more lower. Finally, you go to stage 4, where you have what is called as HIV wasting syndrome with more than 10% of body weight. The patient keeps on losing the body weight, chronic diarrhea, unexplained fever, then multiple infections, maybe bacterial, viral, fungal, any type of infection you want, you will see in this clinical stage 4 kind of a infection, because the CD4 cell count has dropped and the patient is very much prone to all the opportunistic infections. Now, when you look at the epidemiology, this is the 2024 data what we could access. So the new infections around 1.3 million every year, along with people living with HIV around 40.8 million. So daily, on a daily basis, around 3,560 patients are diagnosed, and around 630,000 patients die every year because of HIV. The Africa is the most affected part. On 2/3 of patients living with HIV are in Africa. The South African is the highest number. In South Africa also, Eswatini is the highest prevalence. Around 27% of patients are there. So to create awareness and to further make sure that this particular disease is curtailed. We celebrate a World AIDS Day on 1st December every year. When you look at the Indian scenario, you have a prevalence of around 0.21% in adults, and it is slowly declining. And mostly we have these northeastern states which have a high prevalence. And as far as 2024 statistics are concerned, around 23.2 lakh people are living with HIV. And Maharashtra is the worst affected, followed by Andhra Pradesh, Karnataka, Uttar Pradesh, Telangana, as far as the people living with HIV are concerned. You have the high risk groups, which are extremely high risk groups, which are female sex workers, men having sex with men, hijras, transgenders, and IV drug abusers. Then you have the moderately high risk group, which is the healthcare workers, maybe because of needle prick injuries, hemophiliacs, and other sexually transmitted diseases and infections. Opportunistic infections, most common is tuberculosis and the fungal infections like candidiasis and pneumocystis. Viral infections like herpes simplex and same retinitis and parasitic infections, cryptosporidium, parvovirus, diarrhea, and toxoplasmosis are most common. Now you have the AIDS Control Organization. Basically, in India, it is a NACO, which is basically plans, makes the policies for diagnosis, treatment, for counseling, for each and everything. You have to follow the NACO guidelines as far as India is concerned. Now, we will talk more about NACO guidelines. The next part, we will talk about the lab diagnosis and based on NACO guidelines as well. Immunology wise, what happens? The body, once the virus enters inside, there's a high level of viremia as well as P24 antigen level increases. There's a huge amount of humoral response where antibodies are produced against various proteins, structural, non-structural, everything. But the regulatory proteins and accessory proteins response of immunoglobulins kind of variable. Okay, and the window is around 3 to 12 weeks time. The antibodies to P24 and P55 will slowly develop, and they will be produced at more or less the same time. And as the infection progresses, what will happen is the antibody to P24 will slowly come down, and whenever you see a reappearance of P24 antibodies, that means the patient has ended up in a very severe stage 4 kind of a disease. However, the antibodies to endoproteins persist throughout the infection, and that is not enough to basically bring down the infection. Among the antibodies, the IgG response is a pretty long lasting one. And whatever current assays what we have is good for detecting the IgG antibodies. Sometimes the IgA detection is very useful in serum, mucus secretions, and newborn infants. Now, this is about the first part of HIV for undergraduate students. So, basically, it highlights the main points what you need to know. So, the next part will talk about the lab diagnosis, treatment, and prophylaxis. I hope I have kept this video simple and short. Do join me in the next session where we'll talk about this most important lab diagnosis. We will also discuss about the NACO strategies. Kindly like and subscribe to my channel. Share this video with your friends as much as possible. Thank you.